I thought that I would talk a little bit about neurosurgery and stroke. There is a role for neurosurgical treatments in stroke, and not just blood pressure control and things like that that are pertinent to the neurologic treatment of stroke, but also some aspects of care to help mitigate brain swelling and bleeding that can occur as a result of strokes. And truly, there's disclosures which I have none of. So, we'll talk a little bit about stroke-related conditions that are pertinent to neurosurgery. We'll talk about some of the interventions that we do to treat these things, and then some of the evidence behind supporting neurosurgical treatments in stroke. So I thought I would define stroke to start with, and there's a pretty broad definition. As a matter of fact, a lot of people don't realize that stroke consists of almost anything that's vascular brain. So it's broadly much more than just ischemia or lack of blood to the brain, or even hemorrhagic stroke that's a bleeding kind of stroke to the brain, but also includes conditions like aneurysms, other vascular conditions like AVMs, arteriovenous malformations, cavernoma, which is a capillary venous malformation. And so anything that has a relationship with that starts from a vascular origin in the brain is under the auspices of stroke. So the things that a neurosurgeon would treat in stroke would be things like malignant intracranial hypertension, bleeding from these things that I mentioned, either a hemorrhagic stroke that we'll define a little bit in a little bit more detail later, vascular lesions specifically like AVMs, aneurysms, cavernomas, and also the hemorrhages that result from these types of lesions, and also hydrocephalus, which has a not so obvious link to vascular origin. So malignant intracranial hypertension, this is the mass effect that is created by an ischemic stroke, and as you can see here, what's created in the appearance of the normal brain here being this grayish hue. These are normal fluid spaces in the brain here, and what you're seeing here, this darker area, is actually an ischemic insult that this patient has undergone, where the normal architecture of the brain is disrupted due to lack of blood supply. That sets off a cascade of events leading to swelling that can put pressure on these normal structures in the brain, including the brainstem, concerning secondary problems and pressure on the brainstem, the thalamus. These are the relay centers of the brain, and other important structures, the basal ganglia, that helps relay and coordinate motor control throughout the brain and things like that. Intracerebral hemorrhage also has kind of two components with it. It can also have a malignant intracranial hypertension, but also has injury to the brain as a result of the exposure of the brain substance to the blood. So blood belongs inside a blood vessel, not outside. And blood products and its breakdown products are actually toxic to the brain parenchyma. So back in 2001, a very good surgeon had come up with a easy to understand scale that we use even now to help gauge the severity and linking, severity of a hemorrhagic stroke and linking outcomes loosely to a variety of factors that we're going to go through here in just a moment. But so this intracranial hemorrhage score, or ICH score, was developed that correlates with 30-day mortality, and it constitutes these 5 factors. The patient's Glasgow Coma Scale, which we have defined in previous lectures. Paige might remember what that is. Do you remember what it entails?
You and I are a 15. I think the lowest is a 3, and it's based on verbal, motor, and
Eyes. That's right. I saw you winking, so I knew you were trying to give me a hint. So GCS is one factor that's taken into account, and the patient gets a score for that. And again, I'm going to go over this in subsequent slides, but just to explain each one. ICH volume, this is the actual or approximate volume of the bleed as it's measured, and I'll explain how that can be measured. Whether or not there's bleeding in the ventricular system itself. The ventricle is the natural fluid spaces in the brain, and if there's blood inside of that, as it relates to this hemorrhage, then that is taken into account when these scores are created. The location of the bleed is another important aspect that's considered in scoring this intracranial hemorrhage for the patient, and then also the age of the patient. So this is a breakdown of how this score is made. So the Glasgow Coma Scale, as Paige astutely educated us about, 13 to 15, 15 being normal, that would be a 0 point on the scale. So if the patient comes in and they've got a headache only, but they're otherwise awake and alert and conscious and interacting appropriately, with no confusion, they would get 0 points for that. However, say a severely injured patient who is, possibly posturing or not even reactive at all to noxious stimuli or otherwise, they would get 2 points in this scoring system here for that type of supratentorial brain function. So the volume, again, takes into account greater than 30 milliliters, you get 1 point. Less than 30 milliliters, you get 0 points. Whether or not, it's a yes-no thing, whether or not there's blood in that ventricular system. And 1 point for yes, 0 points for no. And so supratentorial or infratentorial refers to the location in the brain. Supratentorial is considered your higher brain function. So the hemispheres of the brain is considered supratentorial. The cerebellum, brainstem, and other structures are considered infratentorial. And so if you have, so it's of more concern if you have bleeding in that infratentorial space, because it has greater potential to do harm to those brainstem and crucial structures of the brain. And then again, age. They correlated an age greater than 80 years to portend potentially a worse outcome in intracranial hemorrhage. So you take your points based on these criteria and you add them up. And what you find is, and with some research and some studies, population studies here, they found that a score of 1 to 3 showed mortality in a increasing or a linear fashion, but more exponentially as the score increased, you become much more detrimental to the patient, such that a score of 4, for instance, is quite ominous. So, say the patient comes in with, they're a little confused, not quite to the point of needing to be intubated, but are, requiring firm interaction to awaken them, and maybe they do speak to you, but they fall back asleep real quickly. That would get them 1 point. Let's say the volume is fairly great, and that would be, this is probably right around a 30 to 40 milliliter volume here. So let's say they have a bleed like that. that would get them another point. But they don't have blood in the ventricle, so they get 0 points for that. And because it's supratentorial, they also get 0 points, but it's an 85-year-old, so they get a point here. So they've gotten 1, 2, 3 points. The mortality rate is still high, 72%. And then going up from there just makes it all the worse. Now, the way to estimate the volume is a very simple calculation. You measure the greatest dimension of the bleed in the axial, coronal, and sagittal planes. So, Mel, what plane is that? Do you remember? This is the axial plane. This is kind of a top-down view, or technically a view looking up from the feet in a cross-sectional way. A coronal view is when you're looking face-on view, and then a sagittal view is looking from the side. So if you take the greatest dimension, in this case you can measure a sagittal plane, a coronal plane. Now you can't measure a top to bottom plane because we don't have that view here on this particular picture. But if you were to do that, you multiply those values and then you divide by 2. And that gives you the volume, the approximate volume. Does anybody know what that calculation is roughly? Is for something that we all learned when we were maybe this big. It's the volume of a sphere roughly. Yeah. So generalizing bleeds, they kind of end up being kind of a ball. And so we've used that to roughly estimate the volume of these bleeds using that fairly simple calculation. So vascular lesions that can result in hemorrhage, I mentioned arteriovenous malformation. And this cartoon kind of depicts a little bit about how those malformations form. It begins as a shunt from arterial to venous blood flow and develops a intricate capillary network that is due to abnormal blood vessels. So these abnormal blood vessels begin to grow and they recruit, and the abnormality is actually kind of like a tumor of blood vessels, you could say. The blood vessels are definitely abnormal. You can develop aneurysms either inside or in the blood vessels that are preceding an AVM. And so these are highly pathologic blood vessels that can have a particular risk of rupture. An AVM like this is different than a cavernous malformation, which is more like such. You have this abnormal outpouching type formation in the transition from capillary to arterial to venous capillary size vessels. And so as it's described here, this fruit has been used to describe the appearance of these lesions for quite some time, and it's actually true. They're kind of bulbous, multilobulated, abnormal blood vessels that also have a rupture risk, not quite as great as an AVM, but still have the risk of rupture. They are usually not associated with aneurysms, but might be associated with some other types of venous anomalies. There's a process called DVA, developmental venous anomaly, that is similar to this. Now these structures do not involve brain parenchyma. It's not responsible for either providing blood to or taking blood away from anything important, so you can easily resect these. But another associated abnormality called the DVA, that developmental venous anomaly, is, as a matter of fact, responsible. It has an appearance that can be similar to this, but then it's got a venous tail on it, and that venous tail is the coalescence of blood that's coming from the anomaly, but also from normal brain parenchyma. So those you cannot treat surgically, else you cause the patient an ischemic stroke, or a venous stroke, not an ischemic stroke, but a venous stroke. So you have to be able to distinguish some of these surgically and avoid the DVA, but treat the cavernoma. And they can occur together on occasion. And then the AVM behaves somewhat like a tumor, so you can come around it. It does not have brain parenchyma on the internal structure of the AVM, so you can come around it and take the arterial blood supply away from the AVM first, obviously. Then you would dissect around the AVM. Then you would cut the venous supply or the venous outflow, and then you can just remove the AVM. That simply. It's not actually simple, but I mean that in jest. So here's some radiographs of the various abnormalities. This is an This is a CT arteriogram that shows the AVM here, and then a conventional arteriogram, catheter angiogram, that shows the abnormality here with a large draining vein in this fashion. So this would be the arterial supply, or part of it, and this would be the venous outflow. And like I mentioned, this is a pathologic condition, so there's cytokines and growth factors and things like that that the root of the AVM creates, that elicits and solicits angiogenesis, creating more blood supply into the middle of the abnormality that we call the nidus, and so this is how these things can grow. They start as a small structure. They can increase in size over time, and what they do is they can cause vascular steal, robbing.
Sorry, I'm getting a phone call.
Yeah. They cause vascular steal, which diverts the blood flow away from the normal brain into the AVM. So it shunts blood away, so you can get surrounding strokes. In a lot of patients, you'll get this AVM that's surrounded by a cocoon of abnormal, basically dead, because it has pulled all of the blood supply away from that, and in extreme cases, you can cause that effect throughout an entire hemisphere.
Is that what stroke like too?
Potentially, yeah, it can, but it's slow over time. So usually, it's kind of a gradual process. It's more insidious, so it's not abrupt like a stroke you would expect presenting in the ER, but it's something that happens gradually over time, and eventually the patient loses, the use of their right side, for instance, depending on the location of this lesion.
And with the tumor part, you said like a tumor even similar to like the starving of the brain tissue and things around it. Tumors, just general like regular tumors will do the same thing in the body, so it's really similar to what you're seeing. It's an malformation of the blood vessels.
Yeah, the tumors the effect is usually from pressure, not so much a steal phenomenon where they're stealing the nutrients and blood supply from surrounding brain, whereas this is actually diverting that nutrient and blood supply away from normal brain into the lesion, because as you see, these blood vessels are extremely large. These are abnormally enlarged arterial inflow and venous outflow that causes this shunt effect, where the velocity of the blood going through that system is greatly increased compared to the capillary system that's going through the normal brain. So just as a matter of physics, the blood flow is diverted into this abnormal structure away from, bypassing the normal capillaries that go through the normal brain, supplying nutrients and other essential things that we need. So, and this would be the appearance of a cavernoma, or a cavernous malformation. And these sequences here are called gradient echo. They detect, it's an MRI sequence that detects or gives color to blood breakdown products. And you can see patients that have these cavernomas can have multiple. And there's a genetic abnormality that we're not going into here that leads to this, but there's some genetic mutations that can lead to this and cause multiple cavernomas. Some cases they're isolated single lesions. In other cases, and familial cases, you can see a patient who's scattered with innumerable number of these cavernomas. They can occur anywhere in the brain, including the brain stem, and here's an example of one that's in the pons there, a little bit dangerous for the patient. So while the cavernomas don't typically create an explosive rupture like an AVM can, but depending on the location, it can be just as devastating.
Because of the blood byproducts?
Well, yeah, that's right. So the cavernomas, what happens is they tend to, more than rupture, is they just tend to leak. So they leak into the brain tissue around it. The most common presentation for a patient with cavernoma is seizure, because it's rendered the brain around the lesion to be gliotic and abnormal and can be the source of a seizure. So the most common presentation is new onset seizures. In this case, of course, that can get pretty dangerous. If that bleeds, that can cause paralysis. I mean, you can get a pretty profound, acute change in your level of function with a cavernoma in this location. So microangiopathy. These are other more subtle abnormalities that have to do with the microscopic structure of the brain itself. Diabetes and high blood pressure affect the blood vessels in these structures. The cerebellum is the most common location for a hemorrhagic stroke, but these other areas too are quite common. Basal ganglia and thalamus. So that's the basal ganglia is here, the thalamus is here, and those are areas where these hemorrhagic strokes can occur as a result of diabetes or high blood pressure. And what it does is it damages the capillary and arterial structures of the in the blood supply, the vascular tree, that allows those again to leak or even rupture, creating bleeds that look like this. So one would presume this would be a diabetic or a hypertensive bleed here, or say in the thalamus. Say this would be one you might see that would be produced in the basal ganglia. So again, you would score these the same way that we just went over, as far as measuring the size and the location and other factors, and assigning a score to the patient mortality risk.
Do you treat the patient any differently based on that score?
Well, that's a matter of debate. Yes, a patient with a higher score, especially if they're getting a point for being over 80, that plays a role, of course, in your decision making as to, what the risk versus the benefit of an operation is going to be. I mean, anything we decide in life is a risk-benefit analysis. Stepping out your front door, is it more risky to do that? Maybe you get hit by a bus. Who knows? Most likely not. So stepping out your front door is, you have the benefit of coming to work and seeing all the lovely people at Mary Lanning. But in the case of a patient who's, say, 90, who has a bleed like this, or like this, or even this, the risk of an operation there comes with a lot of other potential comorbidities. Infection, pneumonias and other things that might result from having the bleed, being critically ill and things like that. So all of these things, yes, are taken into account in deciding how to treat, when to treat. So, for instance, we had a lady some number of months ago that had a bleed. It wasn't quite that big, actually. It was a little bit smaller than that, but it was on the left side. She was a high-functioning lady otherwise, and she was handling her hemorrhagic stroke very well. She was awake, she was interactive, she was having trouble talking because the bleed itself was in the speech center in the left hemisphere. We did decide to evacuate that. I can't remember her age. I think she was 83 maybe. We did decide to evacuate that because of a combination of factors. You know, her ICH score, for instance, if I remember correctly, I calculated at 3 points. We'll go back and look. Yeah, no, she got 2 or 3 points depending on how you scored this. So her mortality risk was somewhere between 20 and 70%. In talking with the family and other factors about what the patient had been through otherwise or other comorbidities, we decided to pursue that, and it was a good decision. She's had a great outcome. So something that I didn't put into this talk here that I was, that's worth mentioning is that a nuance of intraparenchymal hemorrhages is it has been shown that evacuating a bleed that is more than 30 milliliters in size renders the patient better able to recover from that event. So leaving the bleed versus taking it out, patients did better. Sorry, taking it out versus leaving it, patients did better. So you weigh that with what parts of the brain are affected, what the presumed disabilities might be, and make your decision making that way. And everybody's a little bit different. I practiced with a neurosurgeon who would never operate on any of these because research is kind of iffy on the overall outcome, and we're going to explore some of those papers a little bit later. So diabetes and high blood pressure affect the blood vessels in a certain way that are in these locations here. Now, cerebral amyloid angiopathy is the accumulation of a certain type of protein in, as one ages, you accumulate these proteins in the blood vessels themselves that renders them more fragile. But that location tends to be more in this lobar type area, say here or here. And so it leads to these bleeds as well, but in a different location in the brain. And the mechanism is slightly different. In general, the end result of the changes in the blood vessel are that they either leak or even rupture, causing these bleeds. But the mechanism is slightly different between the different types. So subarachnoid and subdural hemorrhages are bleeds that you can see as a result of, say, ruptured aneurysm or ruptured AVM. And depending on the location of a cavernoma, you might see some subdural. You rarely are going to see any subarachnoid hemorrhage in a cavernoma. But depending on its location, sometimes they can be quite close to the surface. You might see a small subdural hemorrhage. And when at first glance on this scan, you might not be able to tell real well that there is a subdural here, but this thin rim here is demonstrating a subdural hemorrhage that patient has experienced. This being a subarachnoid hemorrhage, likely from a ruptured aneurysm. So how can we make a vascular link to hydrocephalus? Well, we talked in an earlier talk about how brain fluid is made. It's made in a specific organ inside the brain called the choroid plexus, and it produces a volume of brain fluid throughout the day. That volume correlates with about 20 milliliters an hour of production. That means you've got to reabsorb that same amount per hour in order to maintain the normal size of the natural fluid spaces in the brain. So if there's any disturbance of that, then you develop hydrocephalus. Usually the balance is disturbed in the sense of reabsorption is affected, and you can't reabsorb the brain fluid as well. So the mechanism of brain fluid reabsorption is that the so these structures here are actually parts of the choroid plexus inside the ventricle that produces the brain fluid, or CSF, cerebrospinal fluid. So that brain fluid is then disseminated throughout the system, both in the extraaxial and intraventricular space. So the fluid cushion that we all have around the outside of our brain is part of this overall structure, and it's mediated by the arachnoid layer that lives around the brain. So there's several layers of membrane that's around the brain that we all learned at one point. And so the arachnoid layer regulates what happens to the brain fluid, and the way it regulates that is that it will create an outpouching that erupts into the sinuses. I don't have a model here, and I'm realizing now would be nice to have a model to demonstrate to y'all. But the venous sinuses, the dural venous sinuses, are confluences of blood return that's directed back from the brain into those sinuses, comes down and goes through the jugular veins to come back to the heart. And 10% of your blood volume circulates through your brain every minute. So the arachnoid layer creates an outpouching that goes into the dural venous sinus, and it'd be good to have a picture of that too, because there's cartoons all over the place, but I didn't include that here either. So that arachnoid is called an arachnoid granulation, and then so that outpouching then allows the CSF to escape back into the circulatory system, and it's just reabsorbed and circulated along with your blood supply. Well, in the case, for instance, of a subarachnoid hemorrhage or a subdural hemorrhage, those arachnoid granulations are affected, that prevents their ability to create the outpouching into the sinus to allow the brain fluid to then emerge into the vascular tree. And so it blocks the reabsorption of the brain fluid, and you develop hydrocephalus here. So this is a significant enlargement of these natural fluid spaces in the brain that you can see here. So as it turns out, hydrocephalus, certainly under the circumstances of a brain bleed, is, you can directly understand how that's related to a vascular phenomenon, but even beyond that, patients with what we call communicating hydrocephalus have an abnormality in the reabsorption of their brain fluid, so they develop hydrocephalus as well. And that is also an effect that we don't understand terribly well, but an effect on the interaction between the arachnoid granulations and the sinuses that reabsorb the brain fluid. So what kind of procedures do we do in neurosurgery to help treat these things? We can do a hemicraniectomy that allows the brain to swell away from the brainstem instead of towards it. We can evacuate these hematomas directly. We discussed that a little bit. We can place ventriculostomies and ICP monitors into the brain parenchyma to measure and allow a path of egress of the spine fluid when it can't otherwise escape. And these are emergent. These are more emergent procedures that we do to treat this kind of stuff. Some urgent to emergent things involve embolization of a ruptured aneurysm, for instance, embolization of an AVM, And I didn't go into the details of those procedures here, but and also what's becoming more and more widely practiced in stroke is thrombectomy, either mechanical or chemical thrombectomy, where they go in with a catheter inside the blood vessel, and the most effective they've found, even since I've made this talk, which wasn't this morning, by the way, is that the mechanical thrombectomy is more effective than chemical. So it used to be you'd put a catheter in there and you'd drip a thrombolytic solution and allow that clot or that embolus to break down over time.
Similar to like when they do them for PEs. I can't remember what that's called.
Maybe so.
What, the Echoes procedure for PE?
It's
Carney.
Carney, I know. Okay, yeah.
Yeah. Yeah, similar. I'm not sure exactly the techniques they're using there, but I believe they also use mechanical thrombectomy. But it'd be a similar process. And then, so these things can be done on a more emergent basis, especially thrombectomy is done because you're trying to salvage the penumbra of that patient's ischemic stroke. So that's an emergent procedure. These, though, because of the route of the route by which you get to the pathology is fairly easy to do, so you can do it under more emergent conditions. That's performed under more urgent circumstances rather than emergent would be clipping the aneurysm or resecting the AVM, because those are open surgical procedures and the patient has to have a certain degree of systemic stability to, before you undergo that. It can be fairly stressful and taxing on the patient. So otherwise, though, let's say you have a ruptured AVM. It is appropriate to go in emergently and evacuate the hematoma from around that AVM to decompress the pressure that's being placed on the normal structures, and then come in later on a more urgent or even elective basis to treat the AVM itself.
Say someone had hydrocephalus and they had a stroke. Would there be any contraindication for the mechanical thrombectomy?
No. No. You mean if they had a shunt, say, for instance?
Right.
Yeah.
But if they did not have a shunt?
Nope, neither one. Well, you'd want to treat the hydrocephalus first, I think. If you're talking about an acute hydrocephalus, well, you wouldn't really get acute hydrocephalus from an ischemic stroke, but you might get it from a hemorrhagic stroke. And to be more specific, the thrombectomy and the endovascular procedures for stroke, like chemical or mechanical, are more intended for ischemic strokes rather than hemorrhagic. Now, because the hemorrhagic stroke occurs at such a small level of the vascular tree, you don't get an endovascular catheter into those vessels to, I mean, one could imagine maybe you could embolize, say, a bleeding vessel like that from diabetes or cerebral amyloid angiopathy. But the blood vessels that are affected there are of such small caliber that it does not lend itself to that kind of treatment. So then what you're treating when you do these thrombectomies is you're treating ischemic strokes. Those are large vessel occlusions that can be either lysed or otherwise embolus can be treated in more the large vessel. So hemicraniectomy refers to removal of large portions of the skull to allow swelling, and this is the kind of picture that you see after one of those procedures. Hematoma evacuation involves making either a craniectomy or a craniotomy, which refers to replacement of the bone flap in a craniotomy. Craniectomy is you're taking the bone flap off and leaving it off. And then you're making what we call corticotomy. That's an opening through the cortex of the brain to get access to the bleed. So we've got to reach that bleed from some point on the surface here. So obviously you're going to pick the closest point at which it can be accessed. You're going to make a small opening in that part of the brain, using your knowledge of functional anatomy and things like that to avoid, obviously, areas that are vitally important, like language and stuff like that. You don't want to traverse those parts of the brain to get to a clot, only to make the patient permanently aphasic or hemiplegic as a result of your surgery. So once we get access then through the surface of the brain, you can either make just a small opening that you're using instruments to evacuate, or you can, there's small suction devices, there's endoscopic guided devices that we use to evacuate those hematomas.
What determines whether or not you take the flap off completely or not? Is infection reasons? Is it how the
Condition of the brain and the potential for swelling in the future, and that just kind of comes with experience. Most intraparenchymal, say it's a spontaneous intraparenchymal bleed that you're evacuating, most of the time evacuating that bleed gives your brain plenty of space to occupy. You don't worry about the brain engaging in too much swelling after that. But in ischemic stroke, for instance, you would more choose to leave the bone flap off to make room for swelling that will be coming. Because large...
Shall I put it back on?
Yes. Yeah, you eventually put it back on. And the reason you leave it off is that the secondary insult from a hemorrhagic stroke is a lot more confined than it is in an ischemic stroke, where you've deprived a large area of the brain of blood. Then you get a very significant edematous swelling response in a large part of the brain that's going to go on for some time afterwards. Whereas a hemorrhagic stroke, you've created a focal problem where a blood vessel has bled. It's created this blood pocket, so to speak, inside the brain. Once you evacuate that, the rest of the brain around it, for the most part, is fairly normal. Aside from a few millimeters that are directly in contact with that pocket. So, yes, and then you'd replace it at some point later. And we touched on that a little bit last week, where we talked about putting it in the abdomen or putting it in a freezer and coming back at some point later and replacing that bone flap. So, to demonstrate some of these other procedures, a ventriculostomy or an ICP monitor, you come down here and ventriculostomy means you're accessing the ventricle. You're making an opening into the ventricle from the surface of the brain. Ventriculostomy. Kind of like colostomy, right? And so in a ventriculostomy, you're passing catheter down into here so that brain fluid can then escape through that tubing and allow more space. From the thing that we discussed a couple sessions ago, how the skull is a fixed box and only certain things can fit in it. Brain parenchyma, the blood supply that supplies that brain parenchyma, and then the brain fluid. And if you have a disturbance in any of those things, swelling, by removing the brain fluid, you allow more room for other things like the swelling and other, hematoma, if it were to come to it, temporarily, because your body's going to make more brain fluid. And then these intraparenchymal monitors, either this is suggesting a more advanced sensor, a dialysis sensor that can look at various byproducts of what we've measured over the years that creates secondary injury, or just a simple pressure monitor that measures the pressure of that immediate area. just a little bit about some of these technologies, these newer technologies. The embolization of an AVM, you bring a catheter in to the arterial side of the vasculature and you deposit a material that hardens inside. You're basically creating an embolus into that AVM, cutting off the blood supply to that while maintaining the venous outflow so that no more blood is getting in, but the blood is getting out. And eventually, at least as it was conceived originally, the idea is that AVM then kind of regresses and dies, so to speak. Well, it turns out that the way these AVMs behave, they just recruit other blood vessels to come in to supply it. But what we found is that the embolization process is a good adjunct to surgery, so it can decrease the vascular supply to the nidus, making it much less dangerous to resect these, and not only much less dangerous, but much less time consuming. It used to be that these were the biggest operations, longest operations done, you know, aside from splitting Siamese twins, were resecting an AVM, and it didn't used to be rare to hear of these operations going for 12, 24, 36 hours of resecting an AVM. It's going to be a big AVM that takes 36 hours to resect, but in the olden days when we didn't have the ability to embolize part of it, the micro dissection around an AVM could be very tedious.
So what would be the time frame between when you would put the embolus in there?
Usually within a matter of days is what we've determined.
Before it starts going in?
Yeah, I mean, potentially, you know, you're within a week, but outside of a week or certainly a month, you're then seeing new blood vessels being recruited into that. It can be a fairly rapid process. So what we generally do is we talk about embolizing it either singly or in split episodes where you're embolizing parts of it here and parts of it there, and then at the end, you know, within a few days, you're wanting to do the surgery to take it out.
This is a silly question, but what is like the size range that you average? And I just can't imagine all these vessels coming in and trying to, like the size of the vessels themselves.
Well, to give you an example, we'll go back and revisit this picture that we had a little bit ago here. So a lot of these that you're seeing are actually the blood vessels that are supplying normal brain, but this is the pathologic vessel that's actually feeding the nidus of that AVM. So it tends to actually be, when it has a regular blood supply, it doesn't put off these chemical mediators that elicit more blood supply into it because it's got plenty of blood supply. It's like it's got its own mind. It's got plenty of blood that it's getting from the abnormal vessel that feeds it, so it's not so interested in soliciting more to come in. Usually it's one or two larger vessels that are supplying, or a few larger vessels that are supplying the blood supply to the nidus of these AVMs. So you can get in there with these catheters, create the embolization of the key blood vessels, and then you can make your way in a microsurgical technique around the AVM much easier and much more safely with less risk of blood loss.
Is there any risk of stroke if that embolus becomes lodged and goes somewhere else?
It is. Yep, that's one of the risks that must be discussed with the patient, because the other scary thing about doing the embolization procedures is that if that embolisate gets into the venous side, then you've occluded the venous side. You've got blood coming in, but blood's not going out. You increase your risk of rupture. And then coil embolization of an aneurysm, for instance, where you get a catheter in here, you can feed these micro catheters or micro coils. You deploy them into the aneurysm, and the structure of it's called a coil because it the structure is made so that it coils into a ball once you've deployed it. The name is escaping me what we call it before it gets to that point, but basically the structure of the metallic tube that goes into the aneurysm then coils once you've deployed it, causing this effect. And the idea is that when you fill the aneurysm with a coil, you've decreased the blood flow through the coil or through the aneurysm. It clots, and then it's essentially cut off from the vascular tree. So you've eliminated the aneurysm, which was good in theory when it first came out. Turns out there's more to it than that, because what you've done is you may have filled the aneurysm with a thrombus, but the blood flow and blood pressure that created the aneurysm in the first place is bouncing against the bottom of that structure and can cause what we call coil compaction, where the coil gets the structure of the coil becomes tighter and tighter because of the pounding of the blood pressure against it. That can cause a recurrence of the aneurysm because it doesn't completely render the neck unable to expand, but like it does the dome. So the dome of the aneurysm might be treated, but the neck can sometimes not be treated, and properly with a coil, that is. And so they can grow back with time, or the coil can become compacted into the dome and you still have this aneurysm flowing around the bottom. So it wasn't, it's not the end all be all, at least with the current technologies, but it is a good, effective treatment under certain circumstances. Surgical clip ligation of the aneurysms is the tried and true method for treating this, and that's where a alligator clip-like device is placed across the base of the aneurysm to exclude all abnormal tissue. So then you're left with only normal tissue that can and if you've excluded all of the abnormal tissue, then you don't have anything that can expand back to reproduce the aneurysm. Now, of course, that can be affected with, if you don't effectively get in all of the abnormal tissue into the clip, then it can recur, even with application of a clip. So this is kind of a cartoon depicting how a clip comes across an aneurysm, and these are pictures of what the aneurysm might look like. So some of the science behind this iStitch trial, it's an international study of surgical treatment for intracerebral hemorrhage. And what it found was that there was, in general, no advantage to mortality or morbidity with early surgery compared to medical management. So that's where the nuance comes as to what's the right way to treat these. And this is the art of medicine conflicting with the science, because there's papers that I mentioned earlier that demonstrate a better recovery of patients that are salvageable by early removal of the clot. So better recovery, but doesn't affect their overall mortality. So subgroup analysis did show, and this is from this paper supporting some of the other research that's been done, is that early surgery did render a favorable outcome or an improvement in the recovery of the patient compared to medical management, and that was statistically significant. So factors relating to poor outcomes regardless of treatment, and like we talked about earlier, the depth, the location of that bleed. Is it in the brainstem itself? Is it accessible at the surface, or at least relatively accessible? How big it is. I've seen clots that are 100 milliliters in volume. Those are going to be, it's going to be hard to recover from that for anybody. 100 to 150 milliliters of volume is almost the entire hemisphere. And whether or not there's an intraventricular component to this. Now there's some more recent technologies that have come out with this endoscopic assist procedure that I mentioned, where you can put an endoscope in, evacuate the intraventricular hemorrhage, and there's some surgeons and research that suggests that that improves patient outcome as well. But those studies are still in design. So there's another part of surgical management of the ischemic strokes in these trials here. Okay. No. Are they waiting to come in? Okay. Well, the important part here is to demonstrate that there was indeed, when you do a hemicraniectomy in an ischemic stroke, the mortality is improved. But are you creating more disabled people? The answer to that is actually yes, as it turns out. So while mortality was less, disability was higher. However, I think the most important part that they also did with relation to one of these studies was they surveyed patients and family members and found that despite the increase in disability, 77 or 79, 77% of caregivers and patients were glad that they did that despite their disability. So we don't really have much more. That was it.